welcome everybody to the first of the ESID grand rounds for this academic term. We're going to focus today on liver disease in common variable immune deficiency. And we have a great panel today of different people bringing different expertise, who I hope will really help us to clarify what the issues are in CVID liver disease over the next hour and a half. So I'm going to introduce Klaus Varnatz from University of Freiburg, Neil Halliday, who is a hepatologist from University College London, Alberto Quaglia, histopathologist from the Royal Free in London, who's going to present some histology to us today, Celia Jorgensen, who is an immunologist from Oslo, and Jocelyn Farmer, an immunologist from Mass Gen in Boston. Welcome, panel members. My job today is to moderate. So I'm Siobhan Burns. I'm the chair of the ESID Clinical Working Party, and I'm going to do my best to try and keep things rolling along to time. We'll have a number of polls throughout the presentation, which will be opportunities for you to vote for whichever option in management or other things that comes up on the poll. So please do participate in those and put your questions and answers in the Q&A, and we'll get to those towards the end of the session. Okay, so I'm going to hand directly over to Neil to start us with our case. Thank you, Neil.
Great, thanks, Siobhan. So I'll start off taking you through a case of a patient that we were involved with the management of here at the Royal Free Hospital, between us and University College Hospital, and then that I think will prompt some discussion points and some data. So this was a young gentleman who was referred to the Royal Free and University College jointly from a referring centre who had originally diagnosed him almost a decade ago now. So at the time of presentation, he was 30 years old. He presented to his local immunology services with a history of weight loss, fever and drenching night sweats. And looking at the history, he had a history of prolonged recurrent respiratory tract infections for many years predating this presentation. He was otherwise fit and well, bar a history of vitiligo. He took no regular medications and had a young family and was working full time. So he was initially given courses of antibiotics to treat these presumed chest infections. He had extensive investigations, and I've just summarised the key things here. But his symptoms persisted. He kept having fevers, kept having night sweats. And on his cross-sectional imaging with the CT, he was found at the point of diagnosis to have hepatosplenomegaly, evidence of lymphadenopathy, a thyroid mass, and then both interstitial changes in the lungs and bronchiectatic changes. And during this workup, he was found to have low IgG, undetectable IgA and IgM, and was colonised with Haemophilus and Pseudomonas in his chest. So a diagnosis was made in his local centre of common variable immunodeficiency. And he was started on intravenous immunoglobulin. Incidentally, he had this thyroid mass, which turned out to be a papillary carcinoma of the thyroid, which was treated. And then over sort of the years subsequent to his diagnosis, he had recurrent chest infections, which were predominantly Haemophilus. He was put on to azithromycin prophylaxis, sorry for the spelling error there. So azithromycin, and then this was then changed to doxycycline prophylaxis. He was found as well to have cytopenias, so both low platelets and evidence of autoimmune hemolysis, which again fitting with his picture of increasingly complex CVID. And there was no genetic hit on a grid genetics panel. The other organ involvement he had was gut involvement. So pretty early on in his history, presented in 2013, he was found to have giardia, which was thought initially to account for his chronic diarrhoea, but this persisted, and so he underwent GI investigations. So gastroscopy showed features consistent with an enteropathy, and his duodenal biopsies showed evidence of villus blunting and increased intraepithelial lymphocytes, so either consistent with CVID enteropathy or sort of a celiac-like histological appearance. He had a colonoscopy which was normal, and he had a capsule endoscopy which also showed evidence of enteropathy in both the proximal and the mid-small bowel. And because his referring team were initially concerned with could this be a celiac presentation, he was trialled on a gluten-free diet, which gave no benefit, and his genetics were against a diagnosis of celiac, and so it's thought this may relate more to either chronic infection or to a non-infective enteropathy. And then in 2017, for the first time, norovirus was isolated in his stool, and that's been persistent, and we've not been able to clear that for him. He also had evidence of small bowel bacterial overgrowth, which was treated, but despite all of this, he lost weight, he became progressively sarcopenic, and had quite low trough Ig levels, and so it was thought that he probably had an element of both malabsorption and potential protein wasting enteropathy. And then to come to the liver involvement, so he had gut involvement, he had chest involvement, he had autoimmune cytopenias, and he was also noted to have persistently abnormal liver function tests. These are relatively modest. He had transaminases, so his AST and ALT running between 50 and 100, so modestly elevated, and again, a modestly elevated alkaline phosphatase. But his markers of hepatic synthetic function were normal, and he had a full liver screen, so he had screening for hepatotropic viruses, for genetic metabolic causes of chronic liver disease, all of which were negative. So we're left with a young man who's presented with CVID, with multiple organs involved, and with evidence of persistent abnormal liver function tests. So I think this takes us to our first poll. Okay, so the majority of you went for all of the above, and there were a smattering of the others. And absolutely, I think all of these investigations, as we'll see as we come through the discussion of the screening and investigation, have a role to play at some point potentially in a patient's journey, although maybe not all at the outset. So let's take back control. There we go. So we're just going to present a little bit of data, I think, from a few of us here about the evidence for liver disease and CVID. So in terms of the prevalence, this is certainly well recognised, and I'm sure that it's seen in clinic regularly. When you look at the literature, the prevalence is reported is hugely variable, anything between 5% of cohorts 3 to 80%. It really depends on how the cohorts have been selected, where they're located, and how you define liver disease. The sort of working practice we use at the Free, and I'm sure it will vary from place to place, is essentially persistently abnormal liver tests or any imaging evidence of portal hypertension or imaging evidence of liver disease. So we use a very generous generic term to try and catch as many people as we can. So using that at the bottom, so about 40% of our cohort of patients with CVID have evidence of liver disease at the Royal Free, so sort of bang in the middle of the estimate published. And there was another nice Italian study that came out a couple of years ago where they used FibroScan as a screening tool, and they showed an unselected cohort, at least a third had an abnormal FibroScan levels, liver stiffness measurement of over 7.3. So again, it seems to be sort of at least in the 30 to 40% of CVID patients will develop some form of liver disease. And in terms of patterns, so when you're looking at the liver function tests, this data comes from the Oxford group. We published this nearly 15 years ago now, and they showed their patterns of liver test abnormalities. And so the 47 patients who had abnormal liver tests from their cohort, when they excluded those with secondary causes, so things like hepatitis C and malignancies, the commonest abnormality was a persistently abnormal alkaline phosphatase. And even in those who had a normal alk phos, most of those had some other abnormality, whether it be the gamma GT or the ALT was abnormal. And they grouped it into various patterns, and the common patterns were, as shown here, so either in the top, this progressive, sort of inexorable rise in alkaline phosphatase in a significant portion, and then probably the commonest is this persistently abnormal and a bit variable fluctuating elevated alk phos, and that's really sort of the commonest two patterns we see. And then occasionally you'll see, as shown in the third set of graphs, a sort of acute rise with a resolution to normal. So the things to sort of look out for will be a persistently elevated alk phos, often quite modest, although can be persistently rising, and then with transaminase abnormalities as well. And so in terms of the overall patterns, obviously there's that as the initial presentation usually, and then evidence of portal hypertension with or without complications such as ascites and the presence of varices and variceal bleeding. And certainly in our experience, portal hypertension is commonly picked up through cross-sectional imaging, or ultrasound imaging, where you may see portosystemic shunts and varices. And then more more advanced disease can present looking much more like cirrhosis, both histologically and clinically, and with sort of decompensated presentations of ascites, spontaneous bacterial peritonitis, and so on. And then other complications like hepatopulmonary syndrome or an acute hepatitis are also reported. And the differentials are quite broad. This is by no means an exhaustive list, but I suppose the common things to think about will be drug-induced liver injuries, particularly antibiotic exposure in this patient group. Common liver diseases, so could this be common things like fatty liver disease, alcohol-related liver disease? These are common in the general population. They're common in the CVID population too. And then viral hepatitis. Obviously, there's the historical questions of hepatitis viruses, hepatitis B and C being acquired with human blood products, but obviously other forms of chronic viral hepatitis would also need to be thought about. And so in terms of screening, I've just put up here what sort of the UK and the Royal Free plan is. So there's very limited evidence for what to do. It'd be really interesting to hear what the rest of the panel do. The UK, the British Society of Immunology guidance is there on the left, which you can read. So it's regular liver function tests, baseline imaging of the abdomen, repeat the LFTs if they're abnormal, try and avoid hepatotoxic drugs and alcohol, and refer to local specialty for local specialty input where concerned. And on the right is the flowchart we use at the Royal Free. So all patients with CVID have regular liver tests. They have an annual ultrasound scan, and we've now included a baseline FibroScan for all CVID patients. And then if these are abnormal, if there's any evidence of liver disease on these, we exclude other causes of liver disease, and then they're seen in a joint clinic with one of the hepatologists and one of the immunology consultants jointly, and then we will go down the pathway of further specialist investigations, considering things like liver biopsies, assessment of portal hypertension, and so on. And the idea of that is to capture as many patients as we can and assess them. I'll hand back to Siobhan here.
Thanks, Neil. Margarita, could we put the panelists on show, because I'm going to ask them some questions. So if we can collapse the slides, that'd be great. So panel members, we've heard, I guess, a fairly common scenario that we recognise in our clinics, which is CVID patients with liver disease. And as we've increasingly recognised this in CVID, I wanted to ask all of you, what is your approach to screening? And in particular, what tests do you do? Who do you do them for? So do you do them for everybody? Do you do them for selected people? And when do you do them? So who we start with? Klaus, I'll put you on the hot spot first. What's your approach to screening your patients with CVID for liver disease?
So I think the main parameters we will screen in everyone is the liver function tests, and we just choose one of the transaminases and gamma GG, but I'm sure alkaline phosphatase will do as well. And we do annual ultrasounds. And based on this, we basically select patients for further workup, which will be, and I will show that later on one slide, but I think a large spleen will make us do FibroScan, and will also make us do gastroscopy in order to already see early signs of varicosis in these patients.
Okay, so I'm hearing from Klaus, you do liver function, abdominal ultrasound in everybody, and then selected if they're abnormal to go on to other things. Celia, what do you do in your practice?
We do regular liver function tests, either once a year or every 6 months, depending on how severe CVID they have. We also do CT of the abdomen as a screening at the diagnosis, and use that as we do that every year or every third year. And since there's no sort of set approach to do it, I think the clinician do a bit different. Some do FibroScan for the patients, and some use ultrasound. But our initial approach is CT scan to look at portal hypertension. We can also look at the liver, the sign of cirrhosis, but also like lymphadenopathy and other things. So we do that often together with following for long CT for GLLD and so on. So
And do you reserve FibroScan then for patients who have some abnormality on liver function or initial imaging?
Not initial imaging. We sometimes use it to follow the patient, and we also do regularly, if there is a good indication from the CT, we also do liver biopsies.
Okay. And does everybody get a FibroScan or not everybody?
Not everybody.
Okay, so selected patients. Jocelyn, how about you? What do you do in the US?
So some of that is sounding very familiar. So definitely liver function testing on very standard intervals, typically around 6 months is reasonable. I agree. We're typically doing CT scan up front at diagnosis, looking for assessment of the lung. So oftentimes getting the full scan as a baseline assessment. But we've changed a little bit with the data that we'll present with the FibroScan, where if that patient is a complicated CVID subtype, we are bringing up FibroScan in all of those patients as kind of an earlier now modality. And so if either we are still using the alk phos, so if alk phos is 1.5 above upper limit of normal, or the FibroScan is above a cutoff, both Klaus and I will talk about kind of our individual cutoffs for FibroScan. At that point, we're referring them to see hepatology and consider a biopsy at that point.
Okay, so everybody's doing liver function. Everybody's doing some kind of baseline imaging, whether ultrasound or CT, and people are broadly using FibroScans for patients where there's an abnormality of something, either liver function or imaging. Is that fair first summary? Okay, I'm sure there's going to be lots of questions about that at the end. So why don't we move on? So Marguerite, if we can have our slides back again, great. So Neil, off you go.
Yeah. So this is back to our case. So his referring team, in light of this persistent liver abnormalities and his abnormal liver imaging, went on arranged for a liver biopsy for this gentleman, and this was reported as showing features of nodular regenerative hyperplasia, scattered non-caseating granulomas, a very mild lymphocytic infiltrate, and a mild perisinusoidal fibrosis. And we'll discuss the histology. Prof. Quadio will discuss that in a bit more detail, I'm sure. So his team decided to start him on corticosteroids at that point and offered him prednisolone, in part for the gut disease and in part for whether or not it would help treat the lymphocytic infiltrate. There was no impact on his liver function tests, but he was maintained on long-term low-dose steroids and hydroxychloroquine, I think, as a sort of systemic treatment. And I just mention here that he has subsequently developed osteoporosis, which there may well be many contributing factors, but clearly that's one of the complications of corticosteroids to bear in mind. So I'm just going to hand over now to Alberto Quaglio to look at some of the histology data.
Yes, thank you, Neil. Thank you, Siobhan, of course, for inviting. And this is I'm going to show you briefly a few slides on a recent review that we have done on our histological experience with CVID patients. And I have to thank you, Hiroshi Silva and Camila De Brito, who have helped me a lot in sort of looking back at these cases. So, Neil, if we can move to the next slide. The first slide I want to show is that out of 60 patients with liver biopsies that we had to leave a few out. The idea was to concentrate on, in particular, on the aspects of nodular regenerative hyperplasia and fibrosis in these patients. And so we decided to leave out those who had some comorbidities. So, for example, steatohepatitis, acute liver injury in the context of an acute hepatitis type of presentation, or those who had post-bone marrow transplant liver biopsies, or those who developed, for example, lymphoma, and some of them, of course, were not adequate. So just to say that, yes, these patients do not have just the sort of basic changes related to CVID, but they may have other things as well, which may be something to bear in mind, for example, when interpreting FibroScan results. So next slide. Now, in terms of the histological features that we usually see in these patients who do not have other comorbidities, these are three pictures from a case that I reviewed recently. And you can see one on the reticulin stain, you often see this sort of nodular arrangement of the hepatic plates. You have a sort of nodule in the middle surrounded by sort of atrophic hepatic plates, but not bridging fibrous septa. So that's a fairly typical sort of picture of what we call histologically nodular regenerative hyperplasia. If we move to the next slide, please. This is a serious red stain, and you see that that in the same biopsy from the same patient, and you can see that there is a sort of increase in the sinusoidal staining with the serious red in terms of the presence of perisinusoidal fibrosis. And that's something that is actually very common. So nodular regenerative hyperplasia and fibrosis in these patients is certainly not mutually exclusive, but actually they happen very often together. Different degrees of fibrosis. This in this case is mild and focal, but it can increase up to bridging in some of our patients. So if we can go to the next slide, please. And that's the other thing I wanted to show you. This is a CD3 stain, which marks a considerable amount of CD3 positive lymphocytes in the lobule, particularly in the sinusoidal space. And going back to the point that Neil raised, we have sort of carried out this stain now on our cohort of patients, and we are hoping to sort of see if, for example, a cell count could help in prognostication or in guiding management of these patients. If we move to the next one, we also did a CPA analysis, so not just assessing fibrosis on a semi-quantitative scale, but using image analysis to sort of quantify the proportion of collagen out of the total surface of the biopsy in these patients. And very briefly, I'm going to show you a couple of slides with some results. So the next. So as you can see, in a proportion of patients, we couldn't see nodular regenerative hyperplasia, but in the majority was present, and you see that it was very often associated with the presence of fibrosis from mild up to severe fibrosis. So certainly not mutually exclusive. If we move to the next slide, please. And this is the sort of correlation between our semi-quantitative assessment and the CPA. So you see they kind of go together, and perhaps the CPA can help in sort of correlating then with a clinical parameter like fibroscan or other sort of correlates in terms of portal hypertension. And I think this is the last slide for me. If you can move to the, oh yes, that's the final one. One question that we had in mind is whether fibrosis in these patients correlate with age. So in other words, you just see sort of fibrosis building up in time. It doesn't seem to be the case because we had some young patients with severe fibrosis. So maybe there is an heterogeneity in terms of the disease process, and maybe those who present early have, in fact, more severe disease that sort of results in a buildup of fibrosis from an early stage, from an early age. So that's it for me.
That's great. Thanks, Alberto. And just to sort of contextualize what Alberto's seen in the histology data here, so you saw sort of 75% or plus of the biopsies here had evidence of NRH. And this, you know, in terms of then trying to look at what the prevalence of NRH is in the overall cohort of CVID patients, again, there's a range reported. This sort of study in blood from a decade ago suggested less than 1% of patients had evidence of NRH. But then when you look at sort of more focused populations, so in those studies specifically assessing CVID, particularly in those with abnormal liver functions, this sort of rises to up to 10 to 12%. And then when you start to look in patients being referred into liver centres, and particularly those that end up having biopsy, the vast majority of patients on biopsy have evidence of NRH, and that's certainly similar to what Alberto showed you for our data at the Royal Free. But obviously bearing in mind the caveat that was pointed out, there's often other things going on as well, so it may not just be pure NRH. That, and so you have to carefully sort of work through with the pathologists to interpret the findings. And so we come to our next poll question. So a bit of a split vote. So yeah, most people saying potentially something else or nothing else, and then some people considering steroids or sirolimus or mycophenolate. And so we'll perhaps come on to that. Take back control of this.
Margarita, could you show all the panelists again, and we'll ask our panelists about their experience of disease-modifying drugs. So I've actually got a few questions, because what we've just talked through really is biopsies, the results of biopsies and what we do about them. And I thought maybe before we ask the panel members how they treat the condition, how many of you do biopsies regularly, and what are the conditions under which you would do a biopsy for a patient with CVID? Do you do it on everybody with abnormal liver function? Do you have to have something more specific than that? Jocelyn, let's start with you this time. When do you do a liver biopsy?
So again, we had been doing it really for chronically, so greater than 6 months, no other, acute indicator or, cofactors driving it up, but that persistent alk phos elevation was enough for us to typically be sending the patient to hepatology. And most often I would say, yes, we were moving forward with a biopsy. Now we are actually using either or, so an elevated FibroScan or an alk phos level that's chronically elevated, meeting that threshold. Those are typically the patients that are getting biopsied at our center. And it can be a bit tricky. So as we're talking about, they can have not just a single disease etiology. There's also sampling error that can happen in the liver. And, as we're going to talk about a little bit more, NRH in and of itself has a variable presentation. And so I think it does rely on kind of the comfort of the hepatology team at your institutes, and really also the expertise of pathology there.
Mm-hmm. So presumably that means actually quite a significant portion of your CVID patients go on to have a liver biopsy.
Yes.
Okay. Celia, what about you?
We don't regularly do it on everyone. We follow the liver function. If it progress, we will continue with imaging, and normally it will be a combination of liver function test and imaging, either ultrasound or CT or FibroScan, that suggests that something is going on from those investigations. So, and also we have to look at the patient. If they have thrombocytopenia, maybe we will be a bit more hesitant if they have no thrombocytes, and other sort of obesity and other things that might complicate the procedure. So we do an individual
risk assessment, maybe.
Yeah, exactly.
And do you have the impression that you do biopsies frequently or infrequently in this cohort?
I think I must say infrequently. Probably, I don't know, maybe 10 a year or something like that.
Okay.
Yeah.
Klaus, how about you?
So I think I'm the most gray-haired among us. So I think there's a clear change in policy in our center. And I think we were watching alkaline phosphatase for long times and not doing much because there didn't seem to be much clinical effect. The liver functions were all normal, as we said. So I think we watched it for a long time, and I think that has changed. Clear indications in our center are actually the ones which are rather showing up as transaminases we can't explain, because that is not the typical presentation of NRH, and therefore we suspect something else, as in granulomatous, other inflammatory disorders, which you would definitely like to find in biopsies. So these we would definitely biopsy. And with the ones where we do see, so we have not gone as far as Jocelyn went, that we just say after 6 months alkaline phosphatase, you get a biopsy. But I think increasingly we will do this, especially in the context of trying to figure out who to treat and how to treat. Because I think, as we will discuss right after this, I think this will be the challenge. And I think so. This is probably it. Then it probably depends, as Silja said, comorbidities, the risk of biopsies, the patient's decision, obviously. But I think as we hope to have improving approaches to treat biopsies will maybe become more relevant, as I think we will have to discuss right now.
And Neil, can I just ask you to come in then on your approach to biopsying patients? How frequently do you think you're biopsying, and what are your parameters for doing that?
Yeah, I think very similar to everyone else. It's a nuanced decision based on the patient in front of you, their risk profile. Because obviously, a liver biopsy is not risk-free. But absolutely, people who've got evidence of progressive complicated disease, so an abnormal fibroscan, evidence of established portal hypertension, or markedly abnormal LFT, so an abnormal pattern, as Klaus says, sort of transaminitis, would make you suspicious. Is there alternative pathology going on, or if there's progressive disease, and therefore, is there someone we need to consider thinking about treating, or whether they should be treated? So I think definitely abnormal fibroscan, persistently or progressively abnormal liver tests, and atypical patterns. And so we've got a relatively low threshold compared to other sort of settings in hepatology. I think for the CVID patients, biopsy's gone quite out of fashion in liver in general, because most standard hepatological diagnoses can now be made without biopsies or serologically, but clearly that's not the case in CVID. So I think we biopsy a lot compared to other liver indications.
And maybe one other point to make on that is that you mostly are doing transjugular biopsies, which gets around the problems with platelet issues.
So as was picked up, it depends a lot on the support service you've got around you. So a pathology service that are engaged and experienced, but also a radiology service. And so we're very lucky here. We've got a huge radiology service who are willing to do both percutaneous and transjugular. So we will often do transjugular to get wedge pressures at the same time, because whilst they don't necessarily directly change our management, they're very useful sort of background information with these patients. So we do a lot of them transjugularly, and that obviously removes the concerns about if they're thrombocytopenic or if they've got ascites. Anatomically, it's a much easier procedure.
Can I ask here? Sorry, I'm not on the protocol, I know. But
it's okay.
So, because this I did discuss with our hepatologists, and they were just saying this would be basically off-label to do transjugular biopsies in patients who either not have ascites or have very low platelet counts where you have the indication. So they, because we discussed it in a patient where we were thinking about doing it, and then basically said, no, first you will have to take the percutaneous approach unless there are clear indications and risk factors which justify. So how do you do this in your centers?
So, a transjugular approach is safer. And there's very clear evidence that the risk of bleeding, capsular breach is much lower with the transjugular approach. So the risk you do is there's an X-ray exposure with it. So it has to be clinically justified exposure of radiation, but ultimately it's a relatively low dose compared to the number of CTs these patients are typically exposed to. So I think that there's that to consider. Yes, the conventional indications for transjugular are coagulopathy, low platelets, and ascites, but they're not the only reason to do it. The wedge pressures are helpful to get, and I think they've been very useful for us in terms of particularly bringing the cohort together, understanding the pressures and how much abnormality there is in this patient group in terms of both sinusoidal pressure and pre-sinusoidal pressure, which you'd sort of estimate from the clinical features. So, I wouldn't say they're contraindicated. I think that transjugular route is an acceptable route to go in patients if you can justify the radiation exposure, which I think is entirely justified. But again, it depends on your sort of working relationship with your radiologist and your liver team.
Okay, I'm going to just ask Jocelyn and Silja, do you have anything else to say on transjugular versus percutaneous?
I would agree with that. So we're mostly almost exclusively doing the transjugular, and I think I hadn't Klaus run into issues with that. So I think it's going to be maybe insurance and very center dependent in which approach, but also that's I think allowed us to expand it to a greater number of patients feeling like risk to benefit is acceptable. So.
Okay, thank you very much, Celia. Anything from you?
We do mostly transcutaneous biopsies.
Mm-hmm. Okay, so just moving on then to the question we asked in the poll. Do any of you use disease modifying drugs? Do you think any of them work? If you do use them, what do you use and when? So who will we start with? Celia, do you want to go first this time?
Well, I wish I knew the answer to that question. We mostly monitor the patient since we end up doing liver transplantation in some of them if they progress. I don't think the literature support any of the immune modulating drugs. We could sometimes, if it's granulomas in the liver, if it's more like a sarcoid-like picture, we could try corticosteroids. But most of the time, we just monitor the patient because we don't know who's going to progress and who's just going to, be happy with just the slightly moderate elevated liver function test. So mostly monitoring, yes.
Okay. Klaus, what do you do?
Yeah, I love the last answer with the 3 question marks. I think it would have been good if there would have been 3 question marks, you do nothing, or anything else. But to be honest, I think the 3 question marks pretty much represent my thoughts on it. I agree with Celia. I think we have not treated NRH with immunosuppressive treatment, but we have treated patients for other reasons with immunosuppressive therapy. And in my eyes, without having it systematically analyzed, I did not have the feeling that immunosuppression was doing much good to most of these patients. Even so, I must say that I was intrigued that there are T cells in there. So there are potentially. And I think one approach which we have not used, and I'm still hesitant to use it at this time, because I will first analyze our data, but is obviously that you can get steroids in there with budesonide. And so I think if I would see that, I probably would approach it first this way. And if and then I think we'll have to reevaluate. At the moment, I don't see a clear indication, given the picture NIH, not talking about other transaminase high granuloma metastases of the liver. I think these are different chapters which need to be discussed separately. Mm-hmm.
Okay, thank you. Jocelyn, how about you? What do you do?
So I would agree. So there is a huge lack of data in terms of targeted therapies to address NRH specifically. And so really these are patients who have NRH and either they have a gene defect that suggests they should be on a targeted therapy, and then we're additionally monitoring their NRH, or they have a comorbidity. So in this case, we have a question of autoimmune enteropathy. Maybe there's a treatment there in place and we're kind of monitoring as well how the NRH is responding. And so I definitely agree. I think this is a huge need in the field to kind of do a very dedicated approach to NRH. I would also agree, I think in some of even the diagnostic modalities we're talking about, we catch it very late stage. And so I tend to agree with Klaus's pessimism a bit, and that I think in terms of autoimmune enteropathy and GL-ILD of the lungs, I have found this the most difficult, end organ manifestation to really turn around. I think we do need to think about when we are catching this disease, when we are intervening, right? And so I think our discussions about how to catch this earlier maybe, start to carry a little bit more weight. But I really do think we need to follow patients. There are immune cells in the organ. It looks like a liver responding to an immune insult, similar to, we see it with, viral hepatitis. We see it in NRH and other, milieus, right? And so I do think there is an immune insult that plays a role in it. And I think it would be great if we can find a space, early enough and the right targeted agent to really feel like we're definitively turning this around. But at our institute, it's very anecdotal. And I kind of agree again with Klaus's pessimism that we haven't found, that this is the agent that can kind of turn patients around, particularly for late stage cases.
Okay, great. Thank you very much. So lots of research for the future, but let's move on. Oh, Klaus just wants to come in with something.
One question to the panel as well, because I think one of the potential explanations, and we didn't talk much about pathogenesis of this, but I think a lot of people feel that there must be a lot of garbage coming in from the leaky gut barrier into this. And so I'm not quite sure whether it's actually immune, but it may be immune as well. But there may be a lot of toll-like receptor and other kind of stimuli going on in the liver, just because there's the gut barrier is not tight. So therefore, I agree with you. I think maybe we can catch it earlier. But I would think so. And this is my question for you: do you think by trying to improve enteropathy, because your patient also, Neil, had enteropathy clearly, improving enteropathy will do something good for liver? Even so, maybe we don't see it right away, but we see it a year later or 5 years later, or I don't know what later. So do we need to also pay more attention to maybe subclinical enteropathy in our patients where there is maybe already leaky gut, but they don't have full-blown diarrhea and all these questions? And maybe here we could try to be better also, not only focusing on liver.
I agree. I think thinking of it like a systemic process, right? That has multiple different organs involved. I love thinking about it like a systemic process, and that yes, these organs are communicating, the immune system is communicating. So I tend to agree. I think, defining, the natural history of this, the comorbidities that occur along with it, and really working to get tighter control up front. My gut, speaking of the gut, is that's the way to go. But I think we don't have the definitive data to back that's true yet.
Yeah, I completely agree. I think the gut-liver axis, we know in cirrhotic liver disease, we know that leaky gut, increased portal antigen pushes up portal pressures and contributes to exacerbation of portal hypertension. So it feels very real that that's probably what's going on, and the enteropathy is probably important. Looking at in our cohort, enteropathy is strongly associated with the presence of liver disease. Now, whether that's just a marker that this is a multi-system disorder and is occurring in lots of different organs, or whether that's causal, I think no one's shown that yet, but I think that's going to be very likely, and I agree. I think we're often, by the time of seeing NRH, and particularly the fibrotic NRH, we're way down the cascade, and whether or not we can do anything at that point's going to be a real challenge. And identifying it, I think some of the work on FibroScan that potentially gives us a really easy, non-invasive early test may help us identify these patient cohorts early.
Okay, and that's a perfect segue into the next bit, which I think is about FibroScans. So, Margarita, if you could put us back onto slides, that would be great. Thank you. So, Neil, do you want to go ahead?
So to pick up our patient again, so he'd been started on steroids by his local team, as we discussed, was on low-dose steroids, had ongoing symptom of enteropathy, and then had this biopsy showing NRH, and then in 2018 he presented to his local team again with gross ascites. He had cross-sectional imaging with a CT which showed a very enlarged spleen. Importantly, he hadn't occluded his portal vein, so that wasn't the cause for the onset of the ascites. And he was worked up again locally and started on diuretics for spironolactone, and then had his portal hypertension staged at that point with endoscopy, which showed early esophageal varices. And at this point, I'll just put his LFTs down, but at that point, so he had a slightly unusual picture here, and it was more of an ALT predominant. His ALK phos was actually near enough normal. But again, at this point, his synthetic function was preserved. His albumin still in the normal range, although at the lower end. And so he had a complete response to diuretics. His ascites resolved, but he clearly was starting to run into complications of portal hypertension. So it wasn't just there on imaging, it was affecting him clinically as well. So I'll just move on to the next. So yeah, I think it's back to Jocelyn for this.
Yeah, so we're about to segue into some of our FibroScan data, but we just wanted to take 1 minute to kind of focus on the heterogeneity, which you can see within the NRH spectrum. So you definitely don't need to focus on all the data in the slide, but I just want each of these columns basically that you're looking at is a different feature of the histopathology of this disease. And so even if you want to focus on the SF, and so really this is kind of the sinusoidal fibrosis we see, you can see how variable this is. A cohort of 24 patients we looked at Mass General, but you can see how variable that can be. And so this is kind of a consistent theme that's been running through the talk today. Yeah, if you want to go forward. And so, and then we just wanted to point out that, yes, we're focusing on NRH, but within our cohort, we have seen rare cases of things like primary biliary cirrhosis. So just keeping in mind, this is not the only even immune etiology that we see in CVID. So definitely with our cohort as well, NRH is kind of far and away the most predominant liver etiology, but not the only autoimmune or autoinflammatory liver etiology that you may see. And these are very, very sick patients in the two that I've cared for with primary biliary cirrhosis. And so here's some of the data from our institute. So we did look at FibroScan in our patients with CVID. And so what you're looking at is liver stiffness by KPA as measured by FibroScan. And you're looking at that in CVID patients without NRH, which we defined as either normal liver function testing or abnormal liver function testing, later biopsied negative for NRH. So those other etiologies that are kind of being brought into play in discussion today. In comparison to in the second group, NRH with biopsy-proven CVID. And then we also compared it to a group of non-alcoholic fatty liver disease or NAFL patients followed at our institute, because this is really a disease where FibroScan is used already in clinical context. And so what you can hopefully nicely see is this really elevated value of FibroScan in our CVID patients with NRH, actually significantly above either the CVID alone group or even the NAFL group that we followed at our institute. And getting back to this concept that NRH can be so, have these multiple features on kind of histopathology, we wanted to understand which, if any of these were driving that elevated measure of liver stiffness. And so this is the data that you're looking at then on the top. We looked at nodule size, nodule density, fibrosis, the type of fibrosis we were seeing, or sinusoidal lymphocytosis. We looked at them as single and composite scores, and no single or composite feature could really say, this was what was driving up this liver stiffness measurement. And so we took a step back in our cohort and said, okay, well, is it really then the physiology, the change in physiology that's happening in these patients that's leading to this elevated measure of liver stiffness? And this is actually where it started to hit. And so what in the bottom series of data, what you're looking at is the splenic longitudinal diameter. And we saw a linear significant correlation between the magnitude of that splenic enlargement and the measure of liver stiffness, right? So they're positively correlated there. If you as well looked at patients who had an elevated hepatovenous pressure gradient above here, 10 millimeters of Hg, that was significantly elevated in the patients with the larger liver stiffness by FibroScan. And finally, if you looked at patients that just had a clinically diagnosed portal hypertension in the electronic medical record, again, these were the patients who had the elevated liver stiffness. And so if we can go to one further slide, what we ended up looking at is receiver operating curves for liver stiffness, again, by FibroScan measured in KPA, versus going back to that alkaline phosphatase, because at our institute, that had been the metric we were using basically to get the hepatology team involved in these cases. And the ROC curve was actually tighter for the FibroScan data. And so 6.2 or higher was actually able to nicely differentiate the biopsy negative or CVID NRH negative group from the CVID biopsy positive for NRH group. And so that's really the criteria that we're kind of revising the algorithm at our institute to say, yes, should we be using this as a cutoff? And again, towards the goal of potentially picking up NRH earlier in the process of the disease.
Perfect. And thank you, Jocelyn, for the very nice data. And I just wanted to come back to say that, and this we did try to collect our data on portal hypertension, and then your paper came out and we were thinking, oh no, all the good things are already in the paper. So, So the slightly different way we approached it was we didn't have so many biopsies, as I mentioned before. That's why we couldn't compare to NRH and present or not present in histology, but we actually went for clinical portal hypertension signs. So what you're going to see here, and that may explain some of the differences I show, is that we were taking a cohort out of our total cohort, and this were 27 out of 500 patients or 480 patients with clearly clinical signs of portal hypertension. And if you look at this cohort, you can see that this is a multisystemic disease in most of these patients, but you also see in this slide, and at the top is autoimmune cytopenias. I guess you can't read all these labels, where you see that it's classic that it can present before the diagnosis of CVID, which is the line which goes through it. But you see that clinical portal hypertension is rather late in this, which is actually the slightly purplish box at the second from the bottom. So you see the development, you see the enteropathy, two boxes above developing in these, and there you see that many of these patients, of these 27 patients, had several of these complications, but you see a development over time. But as I agree with Neil and also with Jocelyn, the onset of liver disease is much earlier than we see it when we look only for clinical portal hypertension. Next slide, Neil. So it took an average of 12 years almost to have clinical signs of portal hypertension in our patients. And here we went, and this is Anna Maria Globig, who did a really fantastic job in collecting all the data retrospectively of our cohort. And what you see here in the top row, these are the liver function tests, AST, ALT, gamma GT, and ALP, alkaline phosphatase. But in our hands, it was gamma GT, which was separating them the best, but with an overlap. But here you see a lot of out of normal range data for gamma GT, which you don't see as much for the other parameters. And especially transaminases, again, are not necessarily elevated in our patients, as you can see here. The other thing which you can see here, that the function is usually preserved. You do see some with low albumin, and was mentioned before by Neil in our case, in the case of the patient, and also the coagulation may be reduced in some of them, but there are plenty of them within normal range, so they don't allow you to detect these patients. It was interesting, the hemoglobin thrombocyte, this is over time, so this is over a long time. And so this just reflects that several of them had autoimmune cytopenias. That's why they have the very low levels of hemoglobin and thrombocytes in there. But thrombocytes also is one of the measures which went into the ALBI score, which is used in the general hepatic fibrosis cohorts as one of the outcome measures for detecting fibrosis and relevant fibrosis, including for example, thrombocytes in these patients. So we felt that blood parameters were hints, but were not clearly separating clinically overt portal hypertension. Next slide. And then we went for ultrasound and checked the ultrasound. And the frustrating thing, and we lost our first patient to normal flow Vmax in the portal vein, as you can see here, which is not distinguishing patients with and without portal hypertension in this cohort, because they do have still the prograde flow into the liver. It's not much slower than it is in the other patients. There is a high diameter of the portal vein, which is the second or the middle one in the top. However, often it was explained by our ultrasound specialist, oh yeah, they have such a large spleen, that's probably why they have this high diameter. On the very left, you see our liver stiffness measurements with FibroScan. And again, and here we came up with higher stiffness, where we could see that basically everyone above 20 kilopascal had clear clinical overt portal hypertension, which is not helpful because you found that already otherwise. Everyone at 6.5, so which is very close to what Jocelyn just showed you, is relevant and which is clearly significant in the portal hypertension group, higher than in the non-portal hypertension group. But if you just take it as a ROC curve, as you can see here on the top right, there you see we came up with a suggestion around 11, which is higher than what Jocelyn said. But again, remember, this was done for patients who had clinically overt portal hypertension. And the parameter, if you don't have fibroscan at your center, which was our most helpful parameter, was actually the longitudinal diameter of the spleen of 16 centimeters. If you reach that, your risk factor of having portal hypertension is very, very high, and you should assess it, and you should definitely suggest that patients with these high risk factors need to be scoped to really early find signs of portal hypertension and varicosis in these patients. And I think that turns it back to Neil. Yes.
Thanks, Klaus. So we just put a couple of slides in following on from that about, does all of this matter? You know, we've all sort of talked a lot about the presence of liver disease in these patients, but is this, what's the impact of that in terms of patient outcomes? So I've just included some of the data from our cohort here, and this is just crude mortality rates of those with and without liver disease. So over time in our historical cohort, a quarter of the patients who developed liver disease have now died, compared to about 12% of those without. And of those with liver disease, about 1 in 6 have experienced decompensation events, whether that be bacterial peritonitis, portal hypertensive bleeding, and sort of progression to end-stage liver disease. So this is significant, and this does have adverse outcomes for the patients. And these are our survival curves for the cohort that were all free. So the top left, the grey and the blue, those with blue are those with liver disease by our sort of loose definition of abnormal liver test or imaging, compared to those without. And you can see that sort of from a decade to 15 years, the survival curves diverge, and there's significantly impaired survival in those with abnormal, with evidence of liver disease. And if you divide those on the top right by the presence or absence of portal hypertension, it's much more stark. And again, from just over a decade from diagnosis of CVID, you see significant increase in mortality amongst those with established portal hypertension. And then the data below is taken from a paper published by the group in Cambridge a couple of years ago, and they showed very similarly, again in the bottom left, that those with liver-related abnormalities had significantly earlier death than those without, and likewise those with portal hypertension. So clearly liver disease and portal hypertension are associated with poor patient outcomes in the longer term. So how about Siobhan on this? Siobhan, you're muted.
Thanks, Neil. I was just saying Margarita could leave the panel back on again. So the question I want to ask you is, we've seen quite a lot of data showing that portal hypertension is associated with poor outcomes, and that elevated pressures on fibroscans are one way of potentially pulling out patients who might go on to portal hypertension and have poor outcomes. I just wanted to ask each of you in turn, what are the key things for you that you use as predictors of complications or of kind of long-term deterioration? So if you're seeing, because not everybody in Neil's charts who gets CVID with liver disease goes on to develop these complications. So how do we tell? And what for you are the key markers that make you worry that somebody is likely to progress and needs to be watched more carefully? So I'm going to start with Jocelyn. Why don't you go first?
So I think first, kind of what I do is kind of bin those patients into two groups, and we do use, immunophenotype and co-occurring, autoinflammatory comorbidities to say this is kind of a high-risk CVID or a low-risk CVID. And I have had the rare individuals who are kind of liver-only disease, but very similar to the data that's generally been presented, we more often see that as a complication that's co-occurring with other autoinflammatory comorbidities in that individual. And often it's the last one we kind of tend to pick up, and it's presenting when the patient's more presenting with, as we've been discussing today, clinical signs or features that they're progressing to portal hypertension. And so, I think when you're meeting that patient, just kind of binning that patient in a general group to say, is this an individual with CVID I'm worried about or not that, worried about? And then I think individuals who are progressing over time, who have worse immunophenotype, who have more of those comorbidities. And a lot of times it's the individuals where I can't find a gene, or where, I can't get them on targeted therapy for another end organ complication, be it insurance or what have you, who I am struggling with the most to try to find something to manage that individual in a space where there's really not any data or help to kind of guide me. And so I think first is kind of just the overall binning of that individual and understanding their overall clinical trajectory, and those individuals who are high risk by immune phenotype, high risk by those other autoinflammatory features, and who you don't quite have a handle on in terms of their underlying driving etiology. Those are individuals that I give a huge amount of respect to as I'm managing them clinically, and tend to follow a little bit more closely.
Okay. Klaus or Silje, do you have anything you want to add to that? How do you pick out people who you have more concerns about with regards to progression of liver disease?
I totally agree with what has been said. I think one of the parameters which I observed in several of them is increasing cytopenias. So that I don't like to see. Increasing leukopenia, thrombocytopenia, partly probably related to hypersplenism, which increases over time, but there may be other reasons. And then any of these complications of portal hypertension are terrible in this. If they start deteriorating in liver function, again, terrible. This is really progressive liver disease where the liver takes over, also part of the complications of the patients.
Okay. Silje, do you want to add anything to that?
I agree with Klaus and Jocelyn regarding, the comorbidities in many of these patients. And I also think when you get to see portal hypertension on CT, then you need to follow them really closely with the gastroscopies to look for varices before they start bleeding and so on. And then it's probably when you need to refer them to hepatologists to consider a liver transplantation, which we'll come back to later.
Okay, I think I'm going to move us on because I'm conscious that there are questions in the Q&A, and we've still got a couple of other sets of data to show. So, Neil, do we want to go back to the slides?
Yeah, thanks. So to go back to our patient, so he was referred to our service, actually direct to the immunology service rather than the liver service, for consideration of hematopoietic stem cell transplantation. So this is a young guy, previously very fit and well. He's now got multi-system disease, and there was a question of should he be considered for bone marrow transplantation. I'm going to summarise quite a lot of long, complex MDT discussions in this guide, and really it sort of came back down to the bone marrow team turned around and said, look, we're really concerned about this guy. Yes, he's young, but he's very complicated, as I said. He's got autoimmune disease, lung disease, gut disease, chest infections, refractory norovirus, plus liver disease and portal hypertension. So there's a real anxiety about what his outcome would be, and I'll leave that for others to talk about sort of the risks of this. Initial things were done in terms of trying to optimize his nutrition, trying to treat his norovirus with nitazoxanide, with ribavirin. And so there was a real anxiety around what this guy's outcomes would be. And so various teams were asked to get involved, which is really where we first met him, about trying to assess the degree of his liver disease and to feed into these discussions around suitability. And so, as you'll notice, this was sort of mid-pandemic. We got asked to see him, and it's very hard to move anyone around hospitals and get them in. But we managed to get this guy in for 24 hours onto our liver unit to do sort of a one-stop assessment and just restage his liver disease. So by this point, he had a modestly elevated FibroScan, so 7.6. As someone used to looking at cirrhotic FibroScans, that's not very exciting. But as we've heard, this really great data that really sort of quite modest FibroScan elevations can be quite significant. We rebiopsied him, and this again showed evidence of NRH, evidence of a bit of cholestasis, a little bit of inflammation, and on this biopsy, no evidence of fibrosis, which probably just talks to sampling error in biopsy rather than a change in his underlying pathology. His wedge pressure was elevated at 10, so that's the level we'd start to see clinically significant associations if you've got typical cirrhotic portal hypertension. In NRH, this is considered a pre-sinusoidal, so the wedge pressure should be normal or only modestly elevated, but this is certainly, he's got elements of clearly sinusoidal portal hypertension as well as pre-sinusoidal. And we rescoped him, and he had evidence of advanced esophageal varices, and so he was offered beta blockade as primary prophylaxis to reduce his risk of bleeding. We re-imaged him, and he had evidence of portosystemic shunting, but all of his vessels were patent, and he had a big spleen. And by this point, he'd become hypoalbuminemic. His prothrombin time was elevated, his INR was creeping up, and his liver tests remained persistently abnormal. And overall, we did feel that the albumin and the INR were probably more related to nutritional defects with his very severe enteropathy rather than liver synthetic failure at this point. And over this period, he has persistent diarrhea, persistently low serum albumin, continuing infections, and he was discussed at multiple team meetings, both nationally and locally, and in the transplant meetings. And it was felt that overall his risk of mortality from a stem cell transplant would be over 30%. And that was felt overall to be too high risk, particularly in the setting of liver disease. We were asked the question of would we consider listing for transplantation, and we took his case to our liver transplant MDT, and the feeling there was he didn't meet our minimum listing criteria for liver transplant in the UK, which is driven by the UKELD score, which is similar, calculated differently, but similar to the MELD score, which you may be more familiar with. And he didn't meet for any variant syndrome, so non-synthetic indications either. And the feeling was that he didn't meet criteria in the UK, and that liver transplantation wouldn't be in his interest without bone marrow, and particularly in light of his other complications like lung disease and so on. We discussed whether or not TIPS would be suitable for him, and the idea of this was if the bone marrow team were anxious about his portal hypertension, we could potentially put in a portosystemic shunt to reduce his portal pressures and thereby reduce the risk of bleeding or ascites during a bone marrow transplant. And we reached out across Europe to look for the experience of TIPS in these patients, and Klaus will talk of some of that data shortly. And overall, the feeling by the bone marrow team was that his risk for transplantation was too high, and he was declined for a bone marrow transplantation procedure. And so he's returned back to his local team, and he remains actually well and working full time, but clearly with pretty severe complex CVID. So that's the end of the case and where we've left this guy. And I think that he illustrates really the range and complexity of the decision making in these patients and where lots of the unmet needs are. So there's a poll to go back to. And so this is just asking about your experience and what interventions have you used for the treatment of advanced liver complications. I mean, obviously you may well have used more than one of these, but yeah, have you come across using TIPS management portal hypertension, beta blockade and or diuretics for varices and ascites? Have you come across liver transplantation being offered to patients in this setting, or bone marrow transplantation, or combined liver and bone marrow?
I'm going to suggest, Neil, because people can only tick one choice, if they put the highest of those. So if you've done beta blockade plus you've transplanted somebody, put in the transplant, not just the beta blockade, because we're interested to see who's using the more aggressive therapies.
So here we've got probably the commonest used would be beta blockade and diuretics, which is understandable. Quite a few people have got experience with TIPS, which is interestingly good to hear some of that. And then a significant proportion, 20%, with experience of combined liver transplantation and bone marrow. So that's interesting because it's something that we sort of explored here, but remains a sort of evidence-free zone, but clearly an interesting approach that we've certainly got interest in. So clearly quite varied experience as well. So let's move on from the next. So I'll hand over to Klaus, who's got a bit more data on TIPS.
Yeah, just the summary, which again was put together by Anna Maria Globig, was a multi-center study from Europe and Northern America, trying to collect as many patients who have received TIPS for portal hypertension in CVID. So we gathered a total of 13 CVID patients. They were at the age range of 43 to 63. Male-female distribution was 5 to 8. Liver disease, underlying liver disease was NRH, not G, was in 9 patients. Granulomatous liver disease in 2, cryptogenic cirrhosis in 1, hepatitis C-related liver cirrhosis in 1. Reasons for TIPS was secondary prophylaxis for varicosal bleeding in 5 patients, large persisting varices in 6, portal hypertensive gastropathy in 1, and hepatopulmonary syndrome in 1, which I think we can discuss whether that is an indication. Clinically relevant ascites was present in 5 of these patients. And you see the Kaplan-Meier curve of survival post-TIPS. And what we observed is that the portosystemic gradient could be reduced in nearly all of these patients. The spleen size decreased in 6. However, none of them normalized in spleen size. So I guess showing that spleen size has multifactorial probably backgrounds. Moderate ascites was still seen in 8 patients. Hepatic encephalopathy, which is not necessary or unusual part of NRH related portal hypertension and liver disease, was post-TIPS seen in 4, but only in 1 patient was actually clinically relevant. But 6 of 13 died post-TIPS. And you see the reasons for death in the curve. I added them for each patient. So the first patients died relatively short after, I think it was 100 days. After TIPS with an E. coli sepsis, there were staph sepsis, there was sepsis without pathogen noted. 1 patient, which was our first patient, actually, where I realized the problem of liver, died to mediastinitis because she needed a zinc stacking device for stopping her varicose bleeding, which unfortunately perforated her esophagus, and therefore she was for a long time on intensive care and finally died. And then there is staph sepsis and E. coli sepsis. So this clearly is a sign that TIPS bears a risk of sepsis much higher than you usually see in CVID cohorts. And therefore, I think it needs to be taken into account in the decision of providing or recommending TIPS to your patient. We still think we have 1 patient who did exactly like you said, Neil. He came, got the TIPS, and went through transplant, stem cell transplant afterwards, and is doing fine after that. So I think it is worth considering it. I think it is important to realize the risk of sepsis, which may be prevented with antibiotic prophylaxis in these patients, which one could consider if one goes that direction. Needs to be discussed. No data on this available. Thank you. And I think I hand over to Celia already, right? Is that right? Or is it still Neil? No, it's still already Celia. Yeah, all right.
Yep. Go ahead, Celia.
Okay. I'm going to tell you about our experience with the liver transplantation in CVID in Norway. And there's been for many years now a reluctance to perform liver transplantation. And it's obviously due to fear of infections, that if you have a primary immune deficiency and then you put on lifelong immunosuppression on top of that. It's also due to published studies. There are only 26 cases that I could find that has been reported in CVID and liver transplantation with variable outcomes and short observation time. But some of those studies are old, and the etiology and the surgical techniques has changed, and the techniques have improved, and also the immunosuppression is less now than it was 20 and 30 years ago. And I'm also wondering if that's been seen today, and as Klaus also shown, that the liver function test and the INR values are too good to get past the hepatologist and the transplant surgeon so that these patients get accepted for transplantation. Next slide, please. So in 2017, we published some data on primary antibody deficiency. This was 5 patients with CVID and 1 patient with Bruton's. And as you can see, in 1993 and 1998, these patients had liver failure secondary to hepatitis C, which they got from contaminated intravenous immunoglobulin. And after that, we didn't do any liver transplantation for 11 years. But then we were forced to make a rapid decision because this patient that we knew really well got acute portal vein thrombosis, and she had elevated liver function test and bilirubin and INR and so on. So we decided to transplant her, And that went really well. She's still alive 13 years afterwards. But as you can see here, next slide. Next slide, please. The nodule, can you go back, please, Neil? Thank you. That there's a switch from the major cause of severe liver disease in CVID from hepatitis C to NRH. And this is important when you look at all the studies and outcome. Next slide, please. So we have now looked at the data again and a 5-year longer follow-up. And we have excluded the patient from the 90s, which had a different etiology and is almost 30 years old. So we have added 2 more patients that was transplanted in 2017 and 2018. And now we have 6 CVID patients that have undergone liver transplantation at our hospital. And we're the only center that does transplantation in Norway. And I can add that we're only 5 million people living in Norway. So, and the primary cause was that I already told about was the 1 patient had portal vein thrombosis, 2 patients had chronic liver failure with portal hypertension and ascites, but 3 patients had respiratory failure due to hepatopulmonary syndrome. These patients had blue lips, cyanosis, they had low PO2, and they were dependent on oxygen on exercise. So the main conclusion from this study is when we ended the observation time in the end of 2021, that 5 out of 6 of these patients are still alive. They have a median survival of 7.5 years with a range of 4 to 12 years. 1 patient died 6 years after liver transplantation, and this was a sudden and unexpected death. And he'd actually been to his local hospital the same day for a routine follow-up. And there was no change in liver function test, no change in respiratory failure. He was one of the patients with hepatopulmonary syndrome. There were no signs of infections. So we think this might not be related to liver transplantation at all. 1 of these 6 patients was diagnosed with a mild cellular rejection. And we're now looking together with a hepatologist to see how many patients have signs of recurrence of CVD-related liver disease. And it looks like 3 patients have mild signs of recurrence of CVD-related liver disease. Next slide, please. So with regard to the case I've presented now, I just want to tell you what kind of clinical characteristics they had prior to transplantation. So all of them had bacterial airway infection and bronchiectasis. All the patients had splenomegaly and lymphadenopathy. 5 out of 6 had thrombocytopenia, and 3 out of 6 had lymphopenia, and 2 out of 6 had leukopenia. And the common feature from the explanted liver was NRH. And I think 4 of them had fibrosis, and 2 of them had a portal and lobar inflammation with granulomatous disease. We didn't do anything special with these patients compared to other liver transplantation patients. They had initial immunosuppression of prednisolone, tacrolimus, and mycophenolate, which is common in Norway now. Next slide, please. So we think that we see the improvement in long-term outcome of CVID with liver transplantation is due to a general improvement of result after liver transplantation, regardless of diagnosis. We also think it's important that they have changed the immunosuppressive drug regimens, particularly that they lowers the dose of glucocorticoids, because we all know that this high dose of glucocorticoid increases the risk of opportunistic infection. And also it might be important that the indication for liver transplantation has changed from being hepatitis C to NRH, which may also have improved outcome. Next slide, please. So our experience with liver transplantation CVD, that liver function test and INR does not necessarily affect the severity of liver disease. The most important thing is the clinical indication, and that's our complication of portal hypertension, ascites, large spleen, varices, and also for our patient group, respiratory failure secondary to hepatopulmonary shunting. And to get past, you might have to argue for your patient that this clinical manifestation are much more important than the liver function test. So our, although the numbers are small, Our reports show excellent long-term survival in CVID patients after liver transplantation, and they are comparable with overall survival after liver transplantation in non-CVID in the Nordic countries. Thank you.
Okay, Margarita, if you could put all the panel back on for the final discussion. Thanks, everybody. That was really fascinating data, and I'm really particularly interested in the data around liver transplant. I wanted to ask the other panelists: Are any of you have any of you done liver transplant for any of your patients with CVID-associated liver disease? Jocelyn, Klaus, or Neil?
Failed to convince our hepatologist to do so.
Jocelyn?
I would agree. We've had two of very many that have been evaluated, and risk was considered too high in those individuals. And so I really do think it comes down to the guidelines that are used. We can't get patients off of their traditional guidelines, right, as they evaluate patients. And also, there's some data on solid organ transplant and risk in this community, and also concern about recurrent disease in the organ and kind of fairness of, organ allocation in that setting. So those have all been issues that have been brought up at meetings that I've sat in on.
Neil, do you want to add anything to that?
So we transplanted one patient here in the last few years, and the plan had been to do combined series with bone marrow as well. And his liver transplant actually went relatively straightforward despite going into it very sick. He developed early recurrent disease, and that's been reported elsewhere. So he had biopsy changes of CVID-related liver disease, NRH with fibrosis within 6 months of transplantation. It's really, Celia's data is really interesting, and I think really helpful to add into the mix, because the view taken in the UK, or certainly in our centre, was that the minimum expected outcome for a patient should be 50% 5-year survival. And I think each country has their own sort of threshold, depending on organ availability and wait lists and so on. And if you look at the case series that Cambridge put together and pulled all those 26 cases in literature together, once you exclude the hepatitis C's, which is a very different pathogenic process, and they behave very much like traditional cirrhotics, and they can be transplanted successfully without significant infective complications or with manageable infective complications. So clearly transplant's possible in this group. The question is with the underlying pathology. So what they showed is when you exclude the hep C patients, the 3-year survival was 50%. Now, absolutely, there's criticism that that's historical data, there's old immunosuppression regimens, there's old surgical techniques, and survival has improved. But actually, if you look at transplant overall, perioperative survival's improved in liver transplantation, but long-term survival hasn't over the last couple of decades. That's global sort of data. We haven't got better at our long-term transplant outcomes once you survive 6 months. So I think it's really interesting. So the feeling has been, for many of the cases we've discussed, that the risk is too high. I think the data from Norway is really challenging and interesting and helpful for that to feed into those discussions, because I think, clearly it is possible, and clearly some patients can have very good outcomes. What's going to be a real struggle is who is that patient. It's interesting, a lot of pulmonary vascular disease in your patient group, and we've not seen that many of them, but again, is that a particularly good group who have a particularly positive benefit, or perhaps are presenting earlier in their disease process, and perhaps they've got less aggressive liver disease but more pulmonary, I don't know. But I think it's interesting to look at who they are, and I think it's really great data to look at.
Okay, thanks, Neil. I'm going to just try and run a couple of questions off the, we've got about 20 questions or so on our Q&A. And there are a few things that pertain to our discussion. I'm going to ask people to give reasonably brief answers. Celia, do you change your immunoglobulin regimen after you have done liver transplant, or just continue on the same subcutaneous treatment if they're on subcut?
After a while, they go back to what they're normally taking, but they normally use intravenous immunoglobulin post-operative for a couple of months afterwards, just because it's not very convenient to use subcutaneous just after an operation. So yeah, after a while we used it, but we monitor to see if the IgG levels decrease during immunosuppression therapy.
Okay, and presumably you have not used bone marrow transplant in any of these patients. They're liver alone.
They're liver alone, yeah.
Okay. There was a question in the Q&A about whether any of you use splenectomy for management of thrombocytopenia in these patients. Anybody want to come in on that? Do you use splenectomy in your CVID?
We used to do that, but now we use rituximab, and it's been a long time since we've done splenectomies.
Yep, Jocelyn's shaking her head. What?
Yep, same. I think by the time I was coming up into practice, we just don't use it anymore. Yeah.
And sorry, can I just ask Neil about splenectomy and portal hypertension in general? What's the hepatology advice about that?
We're generally reluctant, and in our conversations with our surgical colleagues, they're pretty reluctant to splenectomize these patients. They see all sorts of additional complications, not just bleeding, but problems with shunting and so on post. So again, I can't think of any we've done for thrombocytopenia or splenomegaly alone. I mean, clearly there are settings where it's done, so trauma, splenic rupture, those sorts of settings, but that's a very different question, but certainly not electively.
And Celia, there's another question about the use of immunosuppressive drugs for you after transplant. Have they improved any of the other complications of your patient with CVID?
Yeah, one of the patients who's had the enteropathy for 20 years had the best year of her life, no diarrhea for the first year after transplantation. But when they reduced immunosuppression after a year, it came back. And she had a weight loss of 10 to 15 kilos, but ended up giving her anti-TNF, and she improved and gained weight again. So she's taken back together with the prednisolone. Yeah. So that was a good experience. That's something, if it's the combination that we give after liver transplantation, works on enteropathy of some of these patients.
Okay. There's also a question about whether any of you specifically treat granulomatous liver disease. So we've talked a lot about NRH. Not sure if there's really, maybe Alberto and Neil can say, do you think there's a difference between, is there a separate entity which is granulomatous liver disease, which is not NRH? And if so, do we treat it any differently? Is it different?
Alberto, do you want to?
Well, I think it's hard to draw a line when you call it a separate disease, because histologically you see often granulomas in the context of a liver with nodular regenerative hyperplasia and fibrosis. So I think it would be really difficult. I mean, in some patients you see a lot of granulomas, and in some of the patients you see very few or none, but exactly where you draw the line, I don't think anybody knows.
Does anybody want to say whether they think they manage those patients differently from patients with NRH or not? Or do you not really consider it to be something very different? Jocelyn, how about you?
Well, so we've had a lot of historical cases of granulomatous hepatitis that have gone back, and with, I think we didn't look for it as much, NRH, and I think now we're kind of understanding that this etiology is actually quite common in CVID. And so I do think it's important, if there's any, if that's a really old biopsy, maybe even just getting that biopsy restained with pathological expertise that can be looking for NRH-like features. And I will say, of my case of about, 10 anecdotal, 9 of the 10 were re-clarified as NRH. So I do think that there's a huge overlap within the spectrum of kind of what's been understood as granulomatous hepatitis. If there's really none of those features, not that really liver remodeling component that you're seeing, and the granulomas are kind of huge and above and beyond the feature, then I think you can start to distinguish them. But again, I think there's a huge overlap.
Okay, thanks. I'm going to just remark that the time is 7 or 8 o'clock in Central Europe. So this is the time we said we'd finish. We will attempt between the panel members to produce some answers for the Q&As that we haven't answered. But if the panel members are happy to stay on for a couple more questions for those who still want to hang around, there are some interesting questions about managing gut disease in this in these patients, which I thought maybe it'd be good to get your view on. Are my panelists happy to stay for another couple of minutes.
Okay. Siobhan, if I can give my apologies, but I need to leave.
Alberto, thanks very much for joining us.
Thank you.
So for the rest of you, there were a couple of questions about whether you use antibiotics or things like ursodeoxycholic acid or azithromycin in patients with liver disease, with CVID-associated liver disease.
So, I mean, in terms of the ursodeoxycholic acid, I suppose more for sort of cholestatic liver disease. I mean, obviously we've got huge experience of that in conditions like primary biliary cholangitis, and there clearly is a cholestatic element to this. And we certainly sometimes see evidence of that on biopsy. We haven't been using it routinely, and we sort of and ah about it and haven't come to a strong view, but it's certainly something that I think should be considered. We know that in the problem with urso is it's a very safe drug. It's generally a very well tolerated drug. The side effect profile is minimal. It's usually GI side effects, so it's not a major problem to try it. We know that in, for example, primary sclerosing cholangitis, it makes the biochemistry look a lot better. The alk phos will likely fall, but there's no prognostic benefit in PSC. And in fact, high dose urso was shown to be quite harmful in PSC. So there's a reluctance to jump in because, yes, you may make the numbers look better, but does that alter the natural history? And I think we're really only getting a hand on the natural history of this condition recently, so it's very hard to say. I mean, we don't. That's not to say you shouldn't. So I'm going to sit on the fence entirely on that, sorry.
Anybody else want to give their halfpenny worth of what they do for managing adding these extra things, either antibiotics or ursodeoxycholic acid?
Not antibiotics standardly from us, and I agree. It's really come down to me to the individual hepatologist who's following and kind of their interest in that. And I agree, it makes the liver biochemistries look better. But again, I think the question of is it altering long-term course, and that really hasn't been shown.
And I guess we're all agreed that actually there are a few questions about controlling gut disease. We think controlling gut disease might be a good thing to do, but we don't have much evidence. Is that fair to say? Is that a fair summary? To the enteropathy, Klaus, do you want to say something about this?
I just wondered, Celia, because did you have a look back, and I think you did, with your rifaximin trial? I think it was too short probably to say anything. But if we think that there is translocation of bacterial components playing a role, did you see any changes in liver parameters, or did you follow liver parameters in your rifaximin trial?
We did follow liver parameters because it's safety, but we didn't see any changes in liver function test in that study. It was mostly a negative study. It did affect gut microbiota composition, but it returned to normal after 6 weeks after ending the trial. So, yeah.
Remind me again, how long did you treat?
2 weeks.
2 weeks.
Yeah. But there was a huge difference in the gut microbiota, but no effect on inflammatory markers in the blood, and it returned to normal, like the gut microbiota often do in humans after a certain time.
Yeah. So just from Freiburg, we also don't use antibiotics in the routine setting there, and we give ursodeoxycholic because we like seeing nicer liver parameters. No, I don't know. So, but yeah, no, I no data that it helps. I agree.
Yeah, and I think that probably sums up where we are with many of these things. We need to really have data to try and understand what to do. My last question to the panelists, if you wanted to just summarize, what do you think are the key questions as a community we need to answer going forward for CVID-associated liver disease? What would you say they are?
I think we need to, like Jocelyn and also Klaus mentioned earlier, find a biomarker that we can detect the patient at risk early and then intervene. We are looking at the end results of this immune dysregulation that's been going on for many years. And that's why it's difficult to treat.
Thank you. Jocelyn, Neil, or Klaus, do you want to go next? What do you think are the key things you'd like to answer?
Yeah, I also any controlled trial looking at NRH and CVID would just be such a welcome blanket for me to say. And I agree. I think choosing the right patients for those trials and getting them early enough that we feel like there would be some outcome. And I do think expanding the data, I totally agree from the discussion. It would be great to get that additional data out about liver transplant and outcomes, because we've had a very negative view in the US, I think, about that. So I think expanding the data, the outcomes of these patients, early biomarkers, and really controlled trials looking at immune modifiers, all of those areas.
Okay, Klaus?
I would also, I'm very interested in the pathogenesis. So I think I would love to understand more what's happening between gut and liver. So I think liver biopsies and really controlled trials and analyzing this with new technologies hopefully will give us a bit more answers. What is driving the pathology? That would be my hope in there. And this will hopefully lead then to new trials of targeted treatment. I think understanding more of the microbiota, liver axis, because I think Celia has done a lot of work on this, and I think there will be data in there which will be hopefully helpful. I think we have heard that a lot of people performed liver and bone marrow transplant, much more than I have expected that this number would show up. Please get together and put these data together. I think this is really a start. I think we need that. And yes, as everyone said, I think Celia's data are promising. So I think maybe we can be more courageous in our patients, and we need to find the right timing. I think that is often the difficulty, when to do it in our patients before they're really, really bad, as Neil was sharing with his patient.
Neil, any final last words about what you would like to see us make some progress with?
I think very similar to what everyone else has pulled out. In early phase disease, can we predict who's going to run into trouble? Because I think as we sort of all touched on, we are dealing with the end stage of whatever the process is, whether that be gut liver mediated, whether that be a direct T cell mediated insult on the vascular endothelium in the liver, whatever it may be. So understanding that pathogenesis, identifying biomarkers and clinical predictors of risk, I think is vital. And also to have an informed conversation with patients, because one of the problems I have in clinic, and I don't know how the rest of you manage it, but is sitting there saying to patients, well, we don't really know, and we don't know what your trajectory is going to be, and we don't really know if there's anything effective. And so to be able to inform that conversation would be really helpful. And then absolutely, when we're dealing with the end stage condition, before that, hopefully then can we find disease modifying agents? And I think that will require, I think an RCT will be a huge challenge, but really important. Obviously identifying a clear enough group of patients to run that in and getting enough patients will be really challenging. And then absolutely, what do we do with the end stage patients? These are quite a proportion of young patients who are very sick. The rapid rate of deterioration, we've had several patients over the last couple of years that we've been trying to work up for transplant, and then when they get sick, they get rapidly sick and deteriorate and melt away in front of our eyes. And these are often young. We've had patients early 20s recently who've had terrible outcomes and over a matter of weeks. So I think that trying to predict who will deteriorate and get in and treat early and try and establish a role for transplantation, whether that be hematological, liver, both, in those where they've already progressed beyond any other sort of therapy. So everything everyone else said, really.
Okay, great. I think we should wind up there. I'm going to thank all the panelists for joining. Thank you very much. That was a really fantastic discussion. We have not answered all the Q&A, although I think we've covered quite a decent bit of the flavour. So I think maybe as panel members, we can get together afterwards and just have a shot at putting some answers to the things we didn't finalize, and we will put that on the ESID Clinical Working Party website, where this webinar will be posted afterwards. I think this is a fantastic area, and I do completely agree that we need to put that data together for people who have done combined liver bone marrow, and so we may have a mail shot just asking people to respond if that's you, so that we can try and coordinate some attempt to collate that data. So thank you very much, and and good night. Hopefully see you at the ESID conference. We will be launching the rest of the webinars for Grand Rounds in November, and we're going to focus for the rest of the years on therapies, which is based on the survey that many of you filled in and sent back to us. So thank you if you did that. And we look forward to seeing you at ESID. Bye-bye.